I am Sangmin Park from Seoul National University Bundang Hospital. I have nothing to disclose. Today, we have 5 objectives for biportal endoscopic decompression. After learning from endoscopy setting to contralateral decompression, you will be able to do biportal endoscopic decompression perfectly. Basically, an arthroscope system is necessary. This system is the same as used in knee and shoulder arthroscopy. Camera system, recorder, light source, shaver, pump, arthrocare, scope, fluid line, light cable, camera head. You can use the same instruments as any other arthroscopy surgery, and you do not need any more instruments to do best. In most cases, the right-handed surgeon stands to the left side of the patient. The endoscopic system and C-arm are positioned opposite the surgeon. In some cases, the C-arm may be located on the ipsilateral side of the surgeon. For water-based endoscopic procedures, a waterproof adhesive sheet with a fluid collection pouch is required. In biportal endoscopy, the water pressure should be set under 50 millimeters of mercury due to several complications, but lower water pressure is better. In the interlaminar approach, I like to use midline two portals. In a left side approach, the working portal is located just lateral to the spinous process and interlaminar space. The viewing portal is located 1 centimeter above the working portal. There are several portal methods, and it depends a lot on the surgeon. The most important step in biportal endoscopy is to create a working space. Create a workspace along the working portal and use a Cobb elevator or another tool to create it. It is important to strip the paraspinal muscle from the spinous process and laminar. After creating a working space, you'll see some ragged muscles. Use a shaver and RF system to remove them. After that, you can confirm the working space is enough. After that, biportal endoscopic surgery is performed similarly to a standard ULBD. In ipsilateral surgery, a laminectomy is performed using a burr. A lot of bone or epidural bleeding occurs during laminectomy. Bleeding of cancellous bone is usually controlled with bone wax. Cortical bone bleeding or epidural bleeding is usually controlled with the RF system. After the LF is exposed, the remaining portion of laminar is removed using a kerosene punch. To easily remove the LF, use a penfield to detach the LF from the bone. After detachment of the LF, flavectomy is performed using the pituitary or punch. Undercut the ventral side of the opposite laminar with a burr. Then detach the LF from the bone using a penfield or similar instruments. Finally, flavectomy is done with the pituitary or punch. Remove any remaining LFS with a punch. For hard-to-reach areas, use a foraminotomy punch. Finally, verify that the decompression is complete. In patients with a foraminal disc herniation, we can use the paraspinal approach, partially resect the superior articular process, and remove the disc. Far-out syndrome is difficult to reach with open surgery because the site is deep and blocked by the iliac crest. With biportal endoscopy, access is relatively easy. Identify the L5 transverse process and for the foraminal stenosis, partially resect the superior facet. Then, move laterally, drill the sacral ala. Identify the L5 root and confirm the decompressed root. Even a patient with cauda equina syndrome caused by a severe HIVD can be treated with the endoscope. The disc material can be removed with minimal laminectomy and flavectomy. Even in a highly migrated disc, the disc material can be carefully retrieved and removed with minimal laminectomy. Even in revision surgery, the biportal endoscope allows entry alongside the existing scar. A revision case takes more time, but the root can be identified more safely. A common complication is hematoma. Hematoma caused by hemovac malposition after L4-5 decompressive laminectomy. Hematoma removal was performed with the biportal endoscope. An incidental durotomy may also occur during surgery. In this case, suture was performed because the durotomy size was small. Suture was performed using Prolene 6.0. For durasuturing under the endoscope, a sliding tie was performed using the SMC knot technique, which is used in shoulder arthroscopy. In comparison between biportal endoscopy and microscopic decompression, there were no significant differences between the two groups in the mean ODI score. Biportal endoscopy has some advantages in immediate lower back pain decrease after surgery. Biportal endoscopic surgery is a recently introduced MIS technique. Effectiveness is comparable to open microscopic surgery. Several controversies remain. However, I think there will come a time when biportal will replace open surgery. Thank you for your attention.